I'd like to welcome Ashley Gueret, who's a nurse practitioner with Northern Health. Ashley graduated from Malaspina University College in Nanaimo in 2007 and started her nursing career in Nanaimo Regional General Hospital, where she worked for 10 years in settings that ranged from acute care all the way to community care and adults and children. She obtained her master's degree in nursing and obtained her NP practitioner degree at UNBC in 2017, and then the following year moved to Prince George. Since living and moving in Prince George, she's worked in almost every team-based clinic, but is currently practicing at the Blue Pine Clinic, where she's a clinic lead. Shout out to the local clinic, where she's a clinical lead for nurse practitioners and the clinical implementation lead for nurse out prescribing. When she's not working, she enjoys walking with her two dogs, Pippa and Kona. She'd be remiss without mentioning their names. Cooking, crafting, spending time with her nieces, and enjoying food and drink with company and friends and her partner. So please join me in welcoming Ashley.
Thanks, Graham. So I'm here to talk about benzodiazepine withdrawal and kind of the context of that. These are my disclosures. I am clinical faculty with UBC and UNBC, and I've received honoraria from Pfizer, but that has not affected this talk because nobody would sponsor benzodiazepine withdrawal. So we're all good there. So I'm hoping that you'll be able to recognize benzodiazepine withdrawal, and then we're gonna look at different tools, recognizing that benzodiazepine withdrawal kind of in the context of opioid use is very kind of off. Can you still hear me? Okay. Is very kind of off-label still. We don't have clear guidelines. So, background, we're just gonna go over what are benzos, make sure we know that. What does withdrawal look like? How do we kind of differentiate sedative use disorder? And then we're gonna look at both inpatient and kind of community settings and tools we would use for each. So benzodiazepines are a class of anxiolytic medications that selectively work on GABA-1. So they are inhibitory in nature. So if we think about when we come off of that, it's gonna be an excitatory kind of response. So therapeutic uses of benzos are to make us relax, to give us less anxiety, to perhaps make us forget things like midazolam when we're getting conscious sedation. So when we come off of it, again, all those GABA inhibitory responses are now getting kind of destroyed, and all of the signaling decreases, and we get all of this excitatory kind of signaling in the brain. That kind of leads to an increase in neurological symptoms. So this is really important because this is how we differentiate benzodiazepine withdrawal from like an opioid withdrawal. So what you get in the brain is kind of this kindling effect, and kindling is just like little sparks, and those little sparks turn into bigger sparks, and then you have seizures. So that's kind of the kind of pathway of what benzos are doing in your brain and why benzodiazepine withdrawal is actually so dangerous. Because it's a completely unregulated type of withdrawal, and it can cause seizures and potentially death. It can start as soon as 24 hours after using benzodiazepines. It just depends on what kind of benzodiazepines people are using. All right, so common symptoms of benzodiazepine withdrawal include both the neurological symptoms, such as hallucinations, and an increase in sympathetic nervous system. So again, you're gonna get diaphoresis, you're gonna have some hypertension, increased heart rate, because all of that excitatory kind of process is going on. So what is the diagnosis here? So sedatives include benzodiazepines, barbiturates, anxiolytics, and hypnotics. Use of any of these sedatives can cause significant impairment or distress and qualifies the patient as having sedative use disorder. Patients become dependent on sedatives by either taking them for symptomatic treatment. So we prescribe them to them, they take really high doses, they use them for a long period of time. That's why we say don't prescribe them over 4 weeks. Or they're using them in non-medical settings, so benzodiazepine-contaminated opioids, which is going to be the basis of this talk. So the risk factors for sedative use disorder, again, you've used benzodiazepines for longer than 1 month. You're using them in really high doses. Typically in contaminated opioids, we don't know the doses, so that's pretty hard to define. You have greater insomnia. People that use benzodiazepines because they want to sleep, they tend to become those that become sedative use disorder patients. Concurrent antidepressant use, IV drugs. If they're on methadone already, that's a higher kind of risk factor for sedative use disorder. And those with panic, bipolar 1, or antisocial. So this is the DSM criteria for what qualifies a patient for having sedative use disorder. Basically, there's 11 criteria that address the ability to whether they're able to cut down, whether there's any tolerance, whether they're going to have any withdrawal, and also the implications and kind of the social problems that come with having a sedative use disorder. So are there legal implications? Are they spending a lot of time seeking benzos out? Is this becoming an interpersonal relationship problem? So mild would be you have kind of 2 to 3 of these kind of symptoms from the DSM. Moderate would be 4 to 5, and then severe is 6 and above. So just to kind of context set, what is the prevalence, especially in the north? So we actually did have some interesting data that was collected specifically about our region, and it turns out we, in the north, prescribe a lot of benzodiazepines. The most prescribed were zopiclone, lorazepam, and clonazepam, and that made up 2.5 million prescriptions in British Columbia. Amongst all the local health areas, the Cariboo-Chilcotin had the highest rate of benzodiazepine consumption, as well as the highest rate of the highest doses in the whole province. So these are definitely our patients that are at risk of benzodiazepine withdrawal, not only in a medical setting, but also, again, contaminated opioids. And then overall, kind of the prevalence, sorry. I messed myself up. Can you just scroll down there? Yeah. Overall in Canada, the overall is 11%. So 3.3 patients reported both therapeutic and problematic use of benzodiazepines. And then the highest rate was amongst adults 20 to 24. But 3% of those are using that for non-therapeutic uses. So well, they're not going to get high, but they're going to sleep better. Why are we talking about this? Because fentanyl is being contaminated with benzos, and we have not studied those benzodiazepines. They are often veterinary use or completely novel that we've never seen before. So it's really hard to treat people when we don't even know what to expect. So and it's also important to know the amount of benzodiazepines within opioids is enough to cause abrupt cessation and withdrawal symptoms. So every time we talk to someone who's using illicit substances, it is important to ask about withdrawal symptoms. It's unfortunately completely unpredictable, but I'm going to show you some tools that we can look at about how we would do this in each setting. So withdrawal from multiple substances, including alcohol, stimulants, and opioids, may occur concurrently with non-medical benzodiazepine withdrawal and will require multiple different scales. So the COWS scale, the RASS score, and the CWA-AR. Most patients on OAT will fit the criteria for OUD, but they're unlikely to fit sedative use disorder criteria because they really are not seeking out benzos. They have an opioid use disorder, they're seeking out the opioids. Benzos just happen to be in their opioids that they're using. But remember, just because patients with opioid use disorder do not meet the criteria for sedative use disorder, we still need to assess for that withdrawal component. So some of my pearls for helping clarify if patients have sedative use disorder are using benzodiazepine-contaminated opioids. You want to ask if they're seeking that. I've heard stories from some of our peers that dealers will have a pocket full of just fentanyl and a pocket full of fentanyl laced with benzos, and that patients will actually be able to choose what it is that they want. So it's important to ask, are you choosing that fentanyl with the benzos in it? Do they like the feeling of blacking out? So people who use opioids with benzos, typically they're having really, really long blackout periods. They get kind of nodding off, and then they'll sleep and they'll completely black out and they'll lose periods of time. That is a red flag. That needs more investigation, and you probably really need to address that and look for that withdrawal. Do they go to the specific dealer? Again, how much time are they hunting that dealer down? Are they going to the first dealer they find, or are they going to the guy that they know has the good stuff that's going to get them exactly what they want? Is the patient showing disinhibited behaviors? Are they ramping up? Are they asking more things? Are they calling your office all the time? Are they complaining about not being able to sleep, but constantly, and even though you're like, let's try some trazodone, they're like, only Zopiclone work, or something like that. Then you might want to, again, investigate further into sedative use disorder. And then a physical exam, typically in an opioid user, everything is kind of controlled and relaxed, but someone who is withdrawing off of benzodiazepines, they'll have that fever, hypertension, tachycardia, that kind of thing. Let's talk about inpatient settings. So again, there's lots of information about how to deprescribe your patients off of like benzodiazepines that you have prescribed. There's a whole Ashton manual. It goes through it. We all know it needs to be very low, very slow. That is not this talk. That's not where my expertise lies. This is about non-medical benzodiazepines, very typically in people who are using opioids. That is a totally different game. Again, they don't know how much benzodiazepines in their opioids, and so it is much harder to predict their withdrawal symptoms. So the best treatment for this type of withdrawal is adequate regular doses of a long-acting benzodiazepine. So I've used multiple resources across Canada from Northern Health and BCCSU to kind of give you a good picture of where we're at, but again, very off-label, this type of prescribing. Oh, sorry, with that, I also want to say we used to treat benzodiazepine withdrawal with phenobarbital, and that is no longer recommended. It's also not recommended if they come in psychosis, having hallucinations, that we treat them with antipsychotics if it's likely to be a benzodiazepine withdrawal. They need benzodiazepines. That is the kind of standard across the board from everyone at this moment. So this is kind of what intoxication looks like. Again, they might have those decreased autonomic reactions, confusion, lethargy, altered LOC, decreased muscle tone, slurred speech. You know, you might want to do point of care glucose, obviously get a urine drug screen, serum toxicology, check to make sure they're not pregnant, because that would be very dangerous to withdraw off of things. Lactate lights, creatinine, all your LFTs. Consider those tests for STIs and BBIs if you got them there. Please do an HCV RNA. That's definitely going up in the city. Do not give them charcoal. We do not want them to barf up whatever's going on there. We don't know what they've ingested. Then we can be really putting them into a whole mix of different withdrawal symptoms. And even though we have an antidote for benzodiazepines, inflammasonil, it's actually not recommended unless patients are, you know it's just benzodiazepines they're contaminated with, and they have kind of decreased respiratory rate or something like that, it is recommended to consult the Drug and Poison Center. Think about those adjuncts. In acute withdrawal, you're going to see the opposite of the intoxication, so increased in your heart rate, respiratory rate, BP and temp. Again, they're going to be agitated. It comes with a lot of tactile kind of symptoms. So they feel like they're restless, they can't get comfortable, they feel like there's bugs on them, they feel like there's something under their skin. That is often benzodiazepine withdrawal. It also looks like, oh, really bad anxiety because what do you know? Those contaminated benzos are actually helping their mental health. So people are usually very anxious when they're withdrawing. And then obviously nausea, vomiting, cramping, diarrhea, all those kind of things. So it does look quite a bit like opioid use disorder, or sorry, opioid withdrawal. But it's those hallucinations, the tactile, the neurological symptoms that really kind of separate it. So we do have a tool for benzodiazepine withdrawal. It's called the CWA-B. It's considered to have good face validity, but it's not been tested for specificity or sensitivity in benzodiazepine withdrawal, so it's not in any of the recommendations. I put it there so you can see it, but what is actually considered to be gold standard is the CWA-AR tool. So that's the alcohol revised tool. And it is considered to be much more appropriate. It is validated. We obviously use it widely within settings across all health authorities. So the idea is that we would do CWA-AR every 4 hours if a patient's in severe withdrawal, and if they're in severe withdrawal, every 2 hours, and that you should be waking them up during the night. With patients with any substance use history showing signs of benzodiazepine withdrawal, particularly seizures, agitation, those neurological symptoms, consider administering Ativan right off the bat. Get them to stay in the emergency room department so that they can be assessed, and then continue on with monitoring after that. So they present in crisis, don't wait. Give them that Ativan, like I said, make them more comfortable because it's very, very agitating. And then think about moving to a more kind of validated clinical order set that I will show you in the next few slides. If they present with the agitation, the hallucinations, psychosis, give them benzodiazepines. You can think about perhaps using loxapine, and gabapentin can also be used just because of its GABA properties. But really, what we want to think about is perhaps high doses of benzos and getting them through that initial period to stabilize them, to reduce the risk of seizures and psychosis, and then to taper them off quite quickly. So I'll show you a few kind of ways of doing that. This is from Northern Health. We currently don't have a clinical order set for benzodiazepine withdrawal, although that is in the works right now and coming. This one is the opioid withdrawal. So you can see the red circle there is specifically relating to benzodiazepine withdrawal. So we know what's going to happen. Use the CWA-AR tool and call the 24/7 addiction medicine line through BCCSU if you want some more help. Usually, we recommend diazepam, go to a long-acting, but if they have kind of liver failure, liver problems, or they're elderly, it is recommended to use Ativan instead. Northern Health did just put out some memos about benzodiazepine withdrawal, and so I think they had 3 different resources, and their suggestions are, they have a memo, a practice pointer, and then they had this resource from Vancouver Coastal Health. So while we're working on our own clinical order set, they do recommend having a look at this one. As you can see, uses the CWA-AR score on the side there. And there is kind of mild to moderate scoring, which would be 10 milligrams PO every 1 to 2 hours typically. And if they're 20 or more on the CWA-AR, it's considered to do 20 milligrams, usually every 1 to 2 hours. Now, what I find interesting about this is in most of the guidelines, it says typically people will need benzos up to doses of 100 to 200 milligrams to stabilize, and this only allows for up to 60 milligrams. So it'll be interesting to see what Northern Health comes out with, but you can see this is a 2-page document. It comes with all the nursing orders of when to call the prescriber and things like that. All right, let's talk a little bit about the community setting. So Sandra's a 42-year-old female who uses opioids daily and benzodiazepines when she can get them. She's asking for help to get off everything. Your assessment of Sandra shows that she has stable housing. She injects 250 milligrams of fentanyl 2 to 3 times a day, and on average uses street-obtained Xanax 4 milligrams 3 times a day. She's not been on OAT for the past 6 months. She was previously on methadone, but she didn't like the side effects. She has a history of complicated withdrawal. Oh, she has no history of complicated withdrawal from benzos, never had any seizures, and she has skipped days of benzos, but feels like she needs them because otherwise she gets really irritable and anxious. So what is she going through? What's happening here? Let's work it out. So I like this table because it clearly shows the differences between benzos and opioid withdrawal. Again, you're looking at the benzos separated out, the tactile disturbances, the confusion, the paranoia, the seizures, memory loss, and then all of the hallucination pieces. Clinical experience has shown onset of anxiety is usually within 2 to 3 days. And then there's the big memory losses I find with this. Benzodiazepine use can occur in anyone using illicit opioids for a period of 2 to 4 weeks, especially in an area where fentanyl is likely to be contaminated with benzodiazepines. So that is us right now. A really good way of knowing if that's our community is by using your local drug checking sources. So here in Prince George, that's the Needle Exchange. So they have information that they collect from people who bring their substances in and voluntarily get them tested. And then that gives us really good data about what is happening in our own community. Don't assume that people who have a negative urine drug screen for benzos aren't being contaminated, because again, these are brand new. We don't know where they come from. They are being used in veterinary medicine, and we're not always picking them up. So really make sure you go by an assessment of those symptoms. So patients using illicit opioids should be warned of the dangers of combining opioids with sedatives. Obviously, we all know that. But due to the high risk of toxicity and death, it is not recommended to delay their OAT. So even when you know they're using illicit opioids and there's benzo contamination, OAT is still the best treatment for people who use opioids that would like to not be using as many opioids. However, you should not start it if the patient is overly sedated in your office, because obviously that is a huge risk factor for further respiratory depression and lots of problems down the road. Lots of kind of conflicting information about which OAT medication would be best to use for patients who have contaminated benzos. However, Suboxone, especially if you're going to use a microinduction, shows some safety profile. It actually is protectant in patients who are using opioids and benzodiazepines at the same time. If they're not able to do a microinduction, I find that's best done in people who are very stable, have supportive housing, things like that. It's benzodiazepine withdrawal and opioid withdrawal are much less going to happen when you use methadone and SROM, just because it's a slower titration, and then they can naturally cut down the amount of illicit opioids they're using, also therefore cutting down the amount of illicit benzodiazepines they're using at the same time. So Same thing as inpatient. Community settings, monitoring would be done with the CWA AR. Use it in conjunction with your COWS, your clinical opioid withdrawal scale, and the final score from each scale is less important than the actual signs or symptoms that you're seeing in front of you, though. Goals of outpatient management: alleviate the symptoms of benzodiazepine withdrawal, avoid seizures, create a tapering plan to avoid long-term benzodiazepine prescribing, and create a plan for continuity of care. So again, long-acting benzos are preferred, typically diazepam or clonazepam. Diazepam definitely covered for all patients. Clonazepam is not. So it depends on what type of patients you have in your office. Lorazepam should only be used in the elderly or those with severe liver disease. Start those benzodiazepines if they think they're buying Xanny bars off the street and they think they're 4 milligrams, start at 50% of what they think their dose is, just so that we're not snowing people. And review the signs and symptoms of intoxication and toxicity, withdrawals, make sure they have somewhere safe to store their medications, and make sure you are following these patients up regularly. So for communities, I have two kind of options. There's the gradual taper. So you can see this is recommended to do diazepam 10 milligrams BID for 5 days, then 5 milligrams TID for 5 days, then 5 milligrams BID for 5 days. And that will get you through the bulk of a withdrawal period from benzodiazepines. After that, you can consider whether or not they like some gabapentin. But this is a nice kind of short way to alleviate those symptoms, especially if someone's willing to get off of everything and it's their time to shine and you've got all the supports in place. This is a great way to do it. Maintenance dosing, obviously a little bit more dangerous. We try not to get into this as much, but as the case study we're going through alluded, if they're using 1 to 4 bars of Xanax, you would start with clonazepam probably, and you would do that kind of BID. So for Sandra, we're gonna offer her some oat if she wants it. Probably not methadone, because if they don't like one, it's not worth having the argument usually about going back on that. So pick Suboxone in this case, because it's protective, and we know she's using and searching for benzodiazepines. And then she was using 12 milligrams of alprazolam per day. So a 50% dose reduction would be 6 milligrams of alprazolam. If you convert this to diazepam, it's 60 milligrams or 3 milligrams of clonazepam. So this is, you can find the benzodiazepine equivalency tables to help you. It likely wasn't full-strength Xanax anyways. They have excellent pill presses out there. So even when you think that looks exactly like the pills you're giving them, it probably isn't. It is definitely cut with something else. So tips for enhancing safety. The best advice I can give is if you're gonna do benzos, especially daily benzo with OUD or OAT, sorry, do it in a daily witness kind of, and make sure they go and somebody has eyes on them every single day. So even though typically I will dose things BID or TID, they go and get their OAT, that is witnessed. They will get their first dose of the benzodiazepine at the pharmacy, and then they'll get a couple to take home. I just find this alleviates a lot of stress in me that I am dual prescribing 2 of the most dangerous medications. So, and also make sure you have a treatment agreement in place. So no early refills, single prescriber, kind of spell all this out, urine drug screens, pill counts when it's appropriate. Questions?
I was just wondering, do we know anything about the half-life of the contaminants in that? Do we know how long the withdrawal lasts when it's?
No, unfortunately not. Most of them are quite a bit longer because animals, from what I understand, like metabolize things quite a bit quicker than humans. So when we take things that are meant for animals, our like half-life is probably much longer.
Thanks for your time. Thanks for quoting the coroner's report about the overdose, the reality of the North. Question you might not be able to answer. When you say it's not medical grade benzos, where and how are they being produced? Is it like something like meth that you and me can make at home? I'm just really, I didn't know this until recently, and it really startled me. So do you know anything about that?
Yeah, so just like the new kind of analogs of fentanyl, they're being mass produced in China, and so never tested and coming in. And we do know some of them are veterinarian, but some are definitely completely novel that are being kind of designered in China and coming into the market here.
Dr. Prigmore had mentioned this morning about like recommending the patient in their home setting slowly reducing their alcohol intake. Do you ever recommend that with the illicit fentanyl benzo contaminant?
Graham. I'm sorry, Haley. Do I recommend slowly decreasing benzos?
Like for themselves to like slowly dose themselves slower in the water.
Oh yeah, definitely. So if we're starting OAT, that's kind of the talk I would have, is that as we increase, I'm hoping that they're decreasing their use. And particularly when you're starting OAT, that would be the time to really look for withdrawal symptoms for sure.
Because I see how it's so much easier if you have a 6-pack of beer, next day is 5, next day, but like
Exactly.
benzos is so.
That's a big concern. Biggest concern with opioid use disorder is that we just don't know. People don't know how much they're using. They don't know what's in there. And so education and making sure they have access to peer support workers and drug checking services is really key.
Perhaps time for one, maybe two more questions, but I don't want to deprive you of lunch either. Any last takers? If not, I want to thank you, Ashley. That was fantastic. Really appreciate your presentation. And all right, so just a reminder, lunch will be served in the room where breakfast was served, and try to maintain that one-way flow if you can. Well, actually that won't, because this door is right here, which is when you come through. Maybe they're opening it now. Nope. Oh, hello. We'll see you after lunch.